Dietmar, thank you. Let me show the PowerPoint presentation.
So, hello, good afternoon to all. So, greetings from Triple M Hospital, Chennai, India. So, here is a case. Here is a adult male, age 42 years. He underwent surgery when he was 10-year-old for PDA through left posterolateral thoracotomy. On surgical notes, it was mentioned that there was no PDA was found. Possibility of aorta pulmonary window was considered and advised CAS study, which he did not undergo, and he was lost to follow-up. He is asymptomatic. On examination, he has high volume collapsing pulse. Blood pressure is 150 by 70 millimeters of mercury in right upper limb supine. He has cardiomegaly, hyperdynamic apex, normal S2 split. There is a continuous thrill and grade 5 by 6 continuous murmur in the second left intercostal space. His chest X-ray showed cardiothoracic ratio of 60%, dilated MPA segment, ascending aorta is dilated, and pulmonary plethora. On ECG, it was found that he has sinus rhythm, QRS axis of plus 60, and prominent LV forces with Q waves in LV, in V5, V6. The 2D echo showed dilated LA and LV, moderate size 9 mm aorta pulmonary window located 3.8 centimeters away from the aortic and pulmonary valve, shunting left to right with a peak systolic gradient of 120 and end diastolic gradient of 56. There was no pulmonary arterial hypertension. These are the echo pictures. This is the 4-chamber view. Dilated LALV, concentric LVH, and mild TR are observed here. And this is the short axis view showing the aorta pulmonary window. This is a moderate size 9 mm proximal aorta pulmonary window shunting left to right located 3.8 centimeters away from the aorta and pulmonary valve. This is a dilated MPA segment. So thank you.
So Dietmar, I have with me Dr. Uma Mageshwar. He is one of my senior colleagues. And nurse Sharmila, technologist Mohammed, Alam looking after the patient's comfort, and Janani showing the intracardiac echo pictures. Fluoroscopy live. So what we did was we took arterial and venous punctures. We have the intracardiac echo catheter in the superior vena cava focusing towards the AP window. We had an aortic pulse pressure of around 75 millimeters of mercury. The pulmonary artery systolic pressure was around 40 to 45 systolic with a mean of 30 to 31. And there was a sizable left-right shunt. We tried to get some angiography. However, large aorta, all the contrast gets washed away. Next picture. If we changed the angulation to a marginal LAO, we are able to appreciate the pulmonary artery filling, but it is not a good picture. So we are going to be entirely doing it on intracardiac echo. Show the intracardiac echo. Generally, first picture. Echo picture, first one. Echo live. Show the echo big. So what we have is the ICE catheter in the superior vena cava. The proximal large vessel is the ascending aorta. Show Janani. Yeah, that is the ascending aorta, and distal vessel is the pulmonary artery. Next picture. And that is the AP window. We are able to see the color flow from the aorta into the pulmonary artery. Next picture. Next, so we can see the window. Yeah, we will show the measurement now. Next. So this is the window. It's even better seen here. That is the window. Next picture. So here it is measuring around 10 millimeter. Next picture. So here we got around 12.5. Okay, so that is almost, it is coming to anywhere between 10 to 12 millimeter. Next picture. So okay, so that is the color flow. Show the next fluoroscopy. Go to fluoroscopy live. So the next picture. So what we did was we took a aortic catheter. We dropped a wire into the pulmonary artery. Then next picture. Next. So then, okay, then subsequently, next. So once we got the next one. Once we got the arteriovenous circuit, we then.
Did you have any problems?
No, it was very.
The wire.
No,
No.
it was very easily
Was
going
very
through.
easy.
You can see now. That is the wire crossing through.
Yes, yes, okay.
Okay, so then we got the regular circuit, and now I'll show you live. What we have is through the AP window, a venous sheath from the main pulmonary artery going into the descending thoracic aorta, and we are having echo, show echo big, fluoro small, take away our photos. Yeah, superb. So we are seeing the sheath that is passing through the AP window into the ascending aorta. I want to show the device that we are going to use. Focus now on the camera. So this is going to be a 12.
It's the first time convinced by the eyes. What is your intention? Let me ask just the auditorium here, who have experience with APW? Nobody. Oh, one. From Egypt, super. Oliver, do you have any? You have? How many patients did you treat? 4? Mario?
Just one residual after surgery.
Uh-huh. 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 All? One? One. Okay, what is your intention now?
We are planning to close this with a double. We are planning to close it with a double disc device. We want to have a larger disc on the aorta and a smaller disc on the pulmonary artery. Since it is a grown-up patient, there is going to be.
The pressures were similar.
The pressures.
Pressures were similar. I got it.
No. The pressures on the aorta is 140, and on the pulmonary side is only 50. Pressures are not similar.
Okay. 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 Yes, that's okay.
Since it is a window, I want to be secure, so we have a retention skirt on the pulmonary artery, and there is a 7 millimeter separation between the two to accommodate for the thickness of the ascending aorta and thickness of the pulmonary artery. So I am loading it. This is the memo part asymmetric device made by the Lepu Medical, which is one of the Chinese companies which manufactures nitinol based devices, and we are using one of those devices. So I have
Waist size?
the waist size is 12. 12.
Okay.
So we are not intending to oversize enormously, but the aortic retention skirt is quite large.
So you have a waist of 12. That means in total on the aortic side, 20 millimeters.
Yes, 4
centimeter.
Yeah, 4 millimeter on the aortic side and 2 millimeter on the pulmonary
okay,
side.
Yeah. Okay. Yeah.
So now we are bringing back the device. So this is the window. So you can see the intracardiac echo. Intracardiac echo big. Keep recording, Janani. So intracardiac echo big, fluoroscopy small. Color the AP window.
That is a very nice picture by eyes. I never was so convinced by the eyes and now by this procedure, believe me. But
So-
the device looks a little bit small, is it?
Yeah, but since I have gone 20 millimeters, I think it should work.
Okay. How many experience you have?
10
A
patients
lot
so
of,
far.
I think.
10 patients.
10 patients, wow. I think the most in the world. You have to publish it.
So now the device is in. I'm pushing it up. How do you feel, Dietmar?
That looks very nice, but how do you make the decision now that it is stable? We have had a big discussion before with the ASD occlusion here in Saigon by Tin, but what makes you, let me say, convincing that the device is not too small?
I will do a Minnesota or a Gießen wiggle now.
Uh-huh.
No.
Maybe.
Now
So
that you have the device as a marker, can you turn the ice visualization around the probe that we see the other plane?
can you see that I am actually pulling it? Can you see the fluoroscopy? Fluoro bigger, fluoro bigger. Yeah, now you see. Can you see that I'm actually giving a significant tug?
Yeah, so you have the waist have a little bit an obstruction maybe, and that might be proper the size of the device, isn't? This is your intention to find out that the waist have to be a little bit obstructed.
Yeah, actually now, right now.
The structures of the.
Right now, make the echo bigger. Echo bigger.
Okay.
Almost we have stopped the flows. Record it, Janani. Can you see that there is no continuous flow from the aorta into the pulmonary artery? Can you see, Dr. Dietmar, on the echo?
Yes. Yeah. Do you give contrast through the long sheath on the pulmonary side?
From the aortic side, I will give you.
No, I mean through the, you can, before you release, you make an angiography, an aortic one, but even you can give contrast through the long sheath.
I will do that, but very often there will be an overlap between the right pulmonary artery and the, so we will not get a separation. I'll first give the aortic picture. Give 30 ml at 15 rate. Rotate the. Now the pulmonary artery pressure has reduced to 23 millimeters. Previously it was 42, and now it is 23.
The bad limb is here.
Yeah.
And now I will show you the aortic pressure has increased to 160. The pulmonary artery pressure has fallen to 23. Give a level.
That is fantastic. Looks great. Yes.
Yeah. Come towards Arevo.
My question was.
Start with the.
Arevo. Come more. Enough.
Do you applicate contrast? Yeah. That's a wonderful position now.
Shall I?
In the.
Shoot.
Venus. Yeah.
It looks good. So freeze the frame where it was shown best.
Wonderful.
Enough.
Yeah.
In fact, Dr. Dietmar, intracardiac echo is better. Show the intracardiac echo.
Yeah.
Echo big.
It looks like a closed pot shunt, but not on the pot, but on the water side.
Yeah. So Dietmar, if you are happy, I'm going to release.
Release. I trust in you. I become your fan more and more.
We are fans.
Yes. By Shiva, he's great.
So, Mohammed, one more picture.
Let me say, or let me ask you, how long was your procedure time now in preparing all? It is so fantastic that I really, not only me, congratulate you. I think we gave a good applause. Did you applicate now the... No, it was the long sheet.
I'm going to give through the long sheet right now.
Yeah.
Okay. Give. Are you ready to give about 30 ml at? How much is there? Yeah, 27. Give the 27 ml at. Go to a LAO cranial projection.
W.
To around 30, 40 give. No, not so much. Reduce. No, reduce significantly. Reduce further. Go steep cranial. Lot of cranial. Yeah, lot of cranial. Yeah. Now reduce the projection. LAO.
Looks perfect.
Yeah. Ready to inject? Shoot.
Wonderful, Shiva.
Very nice.
Freeze and
really good.
Congratulations.
What was your procedure time now with preparing all? So it is not so easy operative lesion.
Steve, I think we're going to go for a lecture now.
Shaq, you go for
variant of a truncus, the common trunk.
Yeah, Shaq, you go for the lecture. I'm having a paravalvular leak on echo navigation, which I will show once you are giving us a slot in between. You go for the lectures right now.